The topic for today's discussion is idiopathic intracranial hypertension. My name is Surya Suresh. So let's move on to the topic. Idiopathic intracranial hypertension, as the name suggests, it is idiopathic, increase in pressure in your head, and this is caused by excess buildup of CSF. It can be explained by the diagram that is demonstrated below. In obesity, there is some chemicals like cytokines, adipokines, or if you have excess vitamin A, that leads to increase in CSF production, whereas resorption of CSF is affected by steroid hormones, endocrinopathies, and female sex hormones. That's why this is commonly seen among female in the reproductive age group. These are some risk factors for IIH, namely the endocrinopathies like adrenal insufficiency, Cushing's disease, hypoparathyroidism, hypothyroidism, or excess thyroxine supplementation in children. We know the common notorious drugs, OCP, steroids, and tetracycline. So there are certain other antibiotics like minocycline, doxycycline, nalidixic acid, nitrofurantoin as well. Anemia, chronic renal failure, SLE, increased vitamin as well as very low levels of vitamin A is a risk factor for IIH, and dural venous sinus stenosis, about which I'll be talking in the remaining part of my presentation. Continuing, the symptoms. Usually the patient comes with a headache with the positional component. They complain that they have an excess pressure-like sensation when they are bending forward, and it is associated with double vision, blurring of vision, or pulsatile tinnitus, which is hypothesized as pulsation that is transmitted through the CSF to the sinus walls. Then you can also have photopsia. So headache and photopsia, you may be thinking about migraine, but with the better history, you are going in the right direction of IIH. Physical exam, papilledema. So the optic disc, which is the only part of the central nervous system which we can examine clinically, we can do that in our clinic, or the ophthalmologist usually does that for us, and they comment about the blurring of the optic disc margin. That is a symptom of pressure exerted on the optic nerve. Then you can have cranial nerve 6 palsy because of its anatomical location in the cavernous sinus. Any pressure changes can affect this cranial nerve immediately. Visual field loss is usually described as an enlargement of the blind spot. They can also have infranasal area loss of vision as well. Investigations. So when you got the history exam, now we are looking at the lab works that include CBC, inflammatory markers, and so on. And also we can do an lumbar puncture where the opening pressure will be high, whereas the CSF study will be normal. I'm more interested in the neuroimaging, which I would like to share in the next slide. So this is a normal MRI of the orbit. You can see the nice and round eye, optic nerve. And this is what happens in an IIH patient. There is excess buildup of CSF that causes an enhancement of the optic nerve sheath. The optic nerve is tortuous, and you can see a bulge as well, the papilledema that's you can see in the MRI. And if you notice, if you're comparing with both of these, the posterior pole of the globe is experiencing a lot of pressure, and that is causing a flattening. Transverse sinus stenosis. So if you look at this imaging, the transverse sinus on the right side is wide and open and patent, whereas in the left side, it's stenosed, it's narrow. So the researchers are divided. One who claim that this is the pathology that explains IIH, whereas the other group of researchers claim that this is just pressure impact on the transverse sinus. It is collapsed by the increased pressure in the brain. Treatment. diagnostic lumbar puncture, which becomes a therapeutic one, and sometimes it can lead to spontaneous resolution of IIH, and sometimes it just provides transient relief, and the patient may end up requiring multiple lumbar punctures. Weight loss, we recommend 5 to 10% reduction of total body weight. Acetazolamide, which is the magic drug we prescribe for all patients, it is a carbonic anhydrase inhibitor, which decreases the CSF production. Topiramate, the drug which I love because it helps with the headache. It also helps with weight loss, and it's a weak carbonic anhydrase inhibitor, which helps in reducing the CSF production. And if it is not working, then you have to move on to surgery. Talking about IIHTT, or the Idiopathic Intracranial Hypertension Treatment Trial, it was a big study, a multi-centric one involving 165 candidates, and they found out that acetazolamide and weight loss were effective in reducing vision loss in our patients. Regarding the CSF diversion procedures like the VP shunt, ventriculoperitoneal shunt, or lumboperitoneal shunt, this is an easy demonstration of what is going on. So there is a short catheter that's introduced into the ventricle, and you have a valve and a long catheter that goes down to your peritoneum so that the excess CSF is drained safely to the peritoneum. The complications are displacement of the short catheter or infection of the peritoneal end of the long catheter. Optic nerve fenestration, optic nerve sheath fenestration. This is my demonstration. It's a little bit funny, but I hope you get the concept. There is excess buildup of CSF, and this is something like the MRI that we discussed before. So you just have to create some windows on the optic nerve sheath. Of course, we are not doing it, it's the ophthalmologist. So you can see the CSF escapes and our nerve is saved, and you're literally saving your patient from going blind. Transverse sinus stenting, the most interesting procedure they are doing nowadays. It's just putting a stent in that area where it is stenosed. And you can see the sinus is wide and open. It promotes the CSF resorption by promoting a good venous outflow. So I wanted to talk about this topic specifically because I met a patient who has a stent at Dr. Bernard's clinic. And she got the stent 2 years ago, and she was concerned that she has this recurrent headaches. She required recurrent LPs, and the last LP opening pressure was 18, and she still had this horrible headache. So I looked up at the complications of transverse sinus stenting, and that's pretty scary. Like, you can get a thrombus, you can get bleeding, perforation, whatsoever. These are some of the things that you have to keep in mind while you're managing patients with IIH and a stent. So I want to conclude by telling that early diagnosis is very, very important, because this disease was previously called the benign intracranial hypertension, and they changed the terminology because of the rapid vision loss. And we can see there are multiple treatments available out there, and it's a multi-system disorder. Neurologists, ophthalmologists, neurosurgeons, everyone come together with a patient at our center and helping them to deal with this chronic illness. Further research is warranted because we don't have a clear-cut criteria. Of course, we have some criteria out there, but they are not definitive. We need to improve those criteria, and we need to do more research. Like, there are ongoing research about transcranial Doppler for the diagnosis of IIH. So we can always keep ourselves updated and help our future patients. And that's the end of my presentation. Thank you for bearing with me.